Well, welcome back. I'm Walter Lynn, one of the PTAC committee members. As you may know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on reducing barriers to participation in population-based total cost of care models and supporting primary and specialty care transformation. We now have some time for the committee to reflect on what we learned from our sessions today. We will hear from more experts tomorrow, but we want to take the time to gather our thoughts before adjourning for the day. Committee members, I'm going to ask you to find the potential topics for deliberation document. It is tucked in the left front pocket of your binder. To indicate that you have a comment to make, please flip your name tent or raise your hand in Zoom, Josh. Would anyone like to start? Lauren, thank you.
Since I'm next to you, Walter, I'll go. So there were a lot of really interesting themes today. I'm just going to call out a few and see if others want to comment on that. One of the ones I thought was really interesting from a rural perspective for success and population-based total cost of care models is the importance of a convener, a networks approach, community hospitals serving as sort of a community center, and the need to really share resources across sectors to build integrated teams and have a lot of creativity around how care is delivered that really shifts when we move to all payer models. I thought the comment Chris made about just do it, it's time to move. And we've been moving things around the edges, but in order to get to success, especially in rural, we need to have that alignment. And then also the theme around integration of AI for broader predictive work, the need to have proactive anticipatory disease and symptom management, as well as starting to identify needs, pathways, and road maps for rising risk populations for success, that we really need to be thinking about AI, as well as thinking about the tsunami of older adults and the declining workforce, that we need to get very efficient and be thinking about integration of AI and all of that. And then also, I just love the last presentation. I think it's very interesting. If we can't do this proactively in our existing structures, business is going to step forward to make it happen. So a lot of things to consider.
Thank you, Lauren. Lindsay?
Yeah, thanks, Walter. Yeah, I mean, I think we saw some similar themes here today from previous meetings, but maybe with some nuance that I think is worth capturing. I think hearing that multi-payer alignment is critical for success was not a new theme, but hearing some of the specifics around, what is that critical mass of patients, and somewhere between 40 and 60% of your patients being in these at-risk arrangements is needed to be able to start to make it more profitable to be in these arrangements and move the needle. I think similarly on the multi-payer framework, the idea of how could ECQMs that are multi-payer help to streamline some of the administrative burden of participation in value-based arrangements was an interesting fact today. I think we heard challenges that we've heard before, the technical assistance needed to participate in models remains high. And then the burden of first-year patients is also high. And how can we overcome that? I think we also heard about the burden, the ratcheting effect. I think that is also not a new burden that's been pointed out, but how can we find new ways to adjust for that? I think I'll maybe highlight just a couple, maybe more specific tactical suggestions as we think about payment. Both longer implementation timeline as we think about payment demonstration projects in the future, as well as reducing the time between performance and payment can be helpful. And then I think the specific tactical one I'll call out from Jessica in our first panel is that attribution could be improved by thinking of it at the level of the TIN and NPI instead of just the level of the TIN to avoid attribution by specialty care alone. So some real concrete things that we could do in improving things outside of the blow it all up and head there faster, as Dr. Crow went.
Thank you, Lindsay. I think Krishna was next.
Yeah, thank you. Yeah, I mean, to Lindsay's point too, I think definitely some themes from past discussions and past conversations too. Certainly the multi-payer alignment was key, and I know we have time coming up in September for that, which would be fantastic. How do we sort of make that real nationwide? Particularly the comments on keeping it simple, keeping the measures simple. So I think that simplicity, lowering the barrier to entry, and aligning, I think seems to be a general theme there. Sort of the dollars for infrastructure, data, pop health clearly seem to be consistent. Bless you. Technical assistance, of course. And then I think, Walter, you brought up too the last mile. How do you make sure the incentives get to the doctors in a way that keeps providers engaged in the process? Because given the reconciliation is so long and delayed as well. I thought those were some interesting sort of insights there as well.
Thank you, Krishna. Hanish?
So I think Lindsay summarized some of the key points that I was thinking, literally the points that I stated, which I think were some of the specifics around getting the lead time for the model to really prepare for being able to participate in it, et cetera. When it comes to specialty care, I think that what I heard is that more robust investment in primary care, and especially as we think about the ROI for primary care, and having that be a part of sort of the integral part of care delivery, and then aligning some of the outcomes that we have, not to negative outcomes, right? So someone goes to get a knee replacement or hip replacement, they're not walking out with a DVT, but actually outcomes that are aligned with what the positive outcomes are expected to be, such as mobility or functionality, et cetera. There's an organization called the International Consortium of Health Outcomes Management that specifically states what are the positive outcomes that you would want from a lot of these interventions. And that's at least what I heard the clinician document or comment on. And so as we're thinking about quality metrics, measurable quality metrics, to think of them not as the avoidance of negative things, but really as a promotion of positive things that we hope for our patients. And then the last piece I heard about was advanced care planning. And so advanced care planning being a part of any value-based care model just fundamentally changes how that model is practiced. And this has been demonstrated multiple times, and I think it was shared a couple of times. Having that be a core quality metric can also be consideration.
Thank you, Hanish. Lee?
Very similar. Some of these have already been said, but I was really struck by the richness and the intentionality our first panel discussion, first thing in the morning, brought to this. They had some very concrete, very specific recommendations, which is what we asked them to give us. And some of those have already been mentioned on just the criticality of cash flow in the first few months, the timeline being too long of 12 to 18 months, and how you try to shorten that, but then the risk-taking organization might help get you over that 1 quarter hump where you can start operating. Attribution is mentioned. I thought the concept was interesting that the complexity, when we've talked a lot about complexity over the last 3 or 4 years, but just the complexity is so overwhelming and the inertia is so entrenched that you financially have to be far beyond the tip point to actually tip. We had examples of very favorable arrangements offered to physicians to move out of fee-for-service, and they're just so fearful of change and so entrenched with the inertia and systems that you have to be not 55, 45 is enough to get your tip. You got to be maybe 75% before you think about even considering changing how you practice, which was powerful to hear. Thought the point that rural providers that are traditionally pretty low volume bring a whole new set of standards, and the power of low numbers and risk goes up in that setting. I thought that was powerful. Several people said different ways that MSSP is, you know, clearly kind of a winning model in the Medicare space, but that it lacks one key thing, which was essentially ability to do to work on demand utilization control upstream or utilization control in the organization as a way to weed out waste and unnecessary costs. I thought was interesting. I haven't heard that before. Thought it was interesting to hear that again, back to the risk concepts, that people think actually that how the downside risk is mitigated and controlled is actually more important than how much gain is possible. That was a more important concept. Again, really struck by several speakers speaking to that a margin of 40 or 50% more is needed before you consider it, and that it takes 40 to 50% of your practice's entire panel in a multi-payer alignment to think about tipping over and changing the operations. I'll point out that I think that Cliff's materials from NACOS has done some really nice thinking about benchmarking issues that we've talked about and challenges with some offered solutions that I appreciated, that about risk adjustment, trend adjustment, that are worth consideration. And then the quote of the day from Dr. Snopely, that really in your physician leadership of moving to a value-based care, it takes a madman. So may we all be the madmen in our arenas.
Thank you, Lee. I think Jim was next.
Yeah, just to try to fill in some gaps, you probably would expect me to say something about the rural infrastructure problems in America, but so I will. So I don't want to really disappoint anybody. You know, the big thing that I took away was it's really, really hard to innovate when your ship's kind of holes in it, you know, and we heard pretty loud and clear, and we continue to hear this over and over again, and from experts in the field that, you know, there is a pretty large issue out in the United States that we as we talk about value-based care and expansion of it and increasing participation and creating pathways for increasing participation so that the benefits of value-based care would accrue to people that are really vulnerable. So if you think about all of that, you know, we say, well, you know, let's go for the target. And then we heard that from Chris, you know, to target this. And we had an observation of, you know, we had a lot of people here that were really highly engaged in doing this work and very excited about it. And we heard from Elizabeth in California that the payer, the purchasers, if you will, want to move this way as well. So there's kind of this momentum accruing in large environments, but there's a group of people that are probably likely to be left behind. And so I think that given what we said about market forces and organizational structures and business models that could affect participation decisions, we see critical access hospitals and rural providers being at a somewhat of a disadvantage. And so I would submit that, like we talked about having a pathway for value-based care aggregators, we actually might want to think about advising a particular pathway for the rural communities where the infrastructure is healthcare infrastructure is kind of falling down, not because of value-based care, but in spite of it. I also thought there was one other thing which was just that I wanted to lift up was the idea of a measure being the patient's goal attainment and being kind of aligning, if you will, performance measures across multiple payers in that particular vein, I thought was really, really strong and something I took away from today. So, and then finally, I guess there's this thing with Medicare Advantage seems to have some kind of advantage, and there's a little bit of a wringing of the hands to some extent around the fact that there's more business moving away from fee-for-service and into Medicare Advantage. And we see that fee-for-service value-based care is saving money and producing increased quality in the MSSP model. So we're thinking like, well, could it be cannibalizing value? Well, maybe there's some policy opportunities to recommend to kind of stop some of that disadvantage or the advantage for Medicare Advantage with regard to risk scoring, for example, and some of the ratcheting effects that are adversely affecting the fee-for-service value-based care. So I'll leave it at that, and thank you very much.
Thank you, Jim. Larry?
I compiled my notes here, and what I have, number one, there must be a feasible, visualizable path to savings. So it's got to be attainable. You got to be able to see that you can do it. The time between performance and payment must be reduced. Upfront payments have to be part of the model. We still don't have enough real participation from specialists. I love the line, most specialists participating in ACOs are really not in the ACO. Fee-for-service still has to be made less desirable for the specialist and more desirable for the PCP. Hybrid fee-for-service capitation models need to be investigated. The 40% rule may be the way to get participation. You got to get the hearts and minds. Enough of their revenue has to be at risk or part of and we heard 40% a couple of times. Risk reward analysis has to be realistic and consistent with the business model of the practice. Multi-payer alignment could be a game changer for participation. And then finally, and something that came out near the end that I thought was cool, nested PCMHs may be a way to create cascading accountability for chronic medical care. I thought that was cool. That's what I wrote down.
Thank you, Larry. And Chinny?
Great job, everybody. I'm going to try to fill in some of the gaps that I haven't heard yet. And one of them is from the first panel, they spoke about rural hospitals and the global payment and how well that had worked. And perhaps that's a way to sort of salvage and rescue some of the hospitals that are very needed in those areas right now and differentiate that. One of my favorite quotes was that primary care physicians have a Stockholm syndrome when it comes to
I should have wrote that down.
when it comes to fee for service. And as a primary care physician who practiced, I can tell you that's absolutely true. But I like the idea, and I haven't heard this in all the time I've been on PTAC, is making the primary care payment tax deductible for the patient because of the ROI on primary care being 13-1. I think that's an excellent idea. I also love the idea of sort of a carve out. Some people called it a subcap for primary care. Some people called it subscription payment, but a carve out payment as a mechanism for potentially a prospective type of payment to help primary care physicians do what they need to do and provide that $13-1 ROI. And then a few other things, the technical assistance to implement programs. I do think that's really important, particularly in areas, so we don't incentivize consolidation inadvertently to programs because people just can't have access to data or the technical assistance. And then I think I have one more. The other thing that I noted was having actuarial stability. So as you look at benchmarking and you go through actuarial analysis retrospectively and prospectively, and you're trying to get into programs, figuring out a way that the provider systems or providers have some level of actuarial stability in benchmarking and having some sort of reconciliation that's quick so they can actually get access to the money when they fall short. And then of course, Angela, our favorite person, brought up the 2020 OIG rules around the flexibility and waivers. And I think looking at that program to say like, hey, that was great. Why aren't people using it? And how do we make that more a part of the sort of connective tissue of how care is delivered?
Thank you, Chinny. Josh?
Thanks, Walter. Really great session. I'll just echo what other committee members have said, and many things bouncing around in my mind. I think, I return to kind of what we started with today around kind of barriers to participation, I kind of alluded to this idea of maybe thinking about it as optimizing as opposed to maximizing, in so much as that I think these population-based total cost of care models, I think can and should be improved in a technical way, like PTAC is supposed to be looking at, to be one key offering in the market. But as others have alluded to, there are others that I think are really important. And as I reflect on many conversations leading up to this session, there's so much good stuff that people have said. And where my mind is kind of like, do I need 10 other really good things added to the conversation? Or are there things we might take away from the conversation? Addition by subtraction. They're like things that make sense, but if you really think about it, actually don't serve us as we're trying to achieve these goals with population-based models. And really kind of, to me, comes back down to trade-offs. So while I really appreciate a lot of the kind of concepts mentioned, I think we should really stare honestly and transparently at some of these trade-offs. So for example, multi-payer, I think good for any number of reasons. Other people have mentioned it multiple times, but it requires a simplicity, right? And that simplicity, though, I think has come at a trade-off historically, right? The simplicity can be achieved with primary care and ambulatory measures, which is predominantly what many of these models have been historically, however named, but we struggle with investment in primary care. How can you bring that simplicity to specialty care when every specialist is a little bit different and the context is different and the specialty kind of load or the dose you would need for different populations is different? I think we just have to recognize that things that require simplicity like multi-payer alignment will struggle when you're trying to integrate subspecialists. And I think, to the extent that 1 ounce of data is better than a ton of opinion, if you look at what we've done, really well-intended efforts over a decade in Medicare, you see that with multiple models, what doesn't port over to Medicaid, what doesn't port over to commercial space. I know some of the committee members have really focused on advancing specialty models in the commercial space. Those don't really carry over very easily to others as well. I think that's telling us something. And so the more we say multi-payer, keep it simple, but yes, integrate all specialists, I think that notion doesn't serve us anymore. And I think 3 or 4 of these meetings suggest we should do away with some of that thinking to help us, do bold things like some of our SMEs have suggested. Here's another. I'll just give you one more for time. When we think about scaling up participation, say within a payer, such as Medicare, what's the trade-off between that then and the multi-payer that I just mentioned? Getting more people into different models in one payer doesn't necessarily get us wide with multi-payer because others have mentioned today this idea of one size won't fit all. So if you scale up, you are accepting complexity. The table we put forward in the PCDT has got complexity in it, meaning it's got multiple rows and multiple columns. I think this is a feature. This is not a defect in the system. But if we embrace that complexity, we have to set aside some degree of simplicity, right? So scaling up within a payer, I think, and scaling out wide, there is a trade-off there. And so I think they're just, as I've been thinking through this, maybe I'll kind of summarize more tomorrow, but there are 3 or 4 or 5 things in my head where I think expunging these ideas from our conversation going forward will help us because we've heard over many meetings, including today, really nice things, but how do they fit together? And I worry some don't. And so really love the conversation. I think this is all really helpful for moving the dialogue forward. I look forward to thinking more about the technical pieces with the rest of the committee members and the subject matter experts. But what are those ideas that don't serve us anymore that we need to take off the table? That's where my head is at after a really productive day. Thanks.
Thank you, Josh. Just in the interest of time, I'll just make a couple really brief remarks in terms of my thoughts. After Jim's PCDT presentation, that highlighted really well the plateauing of participation in PB TCOC models, ACOs. I had said fee-for-service is the real villain here, and I think that was a theme that ran strongly through the sessions today. Since I think Chinny said, quoted Dr. Crow's Stockholm Syndrome of fee-for-service. I'll use the other one. Fee-for-service is the devil to the PCP. All the way through to the very last session where Elizabeth said the muscle memory of fee-for-service is very strong, and I think the idea that there are viable business models that thrive under fee-for-service, I think presents a real challenge to increasing participation in value-based care. The other thing I just mentioned along those same lines is the comment by cliff costs around how ACOs are held to a stricter financial performance expectations without approaches like neural networks or utilization management. And I think that's also very important to grasp as well, because if total cost of care models were entering into a boxing ring with fee-for-service, it's like we're entering into the boxing ring with one arm tied behind our back. We don't have the tools that Medicare Advantage plans have to make these models succeed. And so I just think there might need to be additional considerations over time about adding tools to the PBTCOC toolbox to help these models be more successful. With that, I'm going to turn the time over to Chinny to close this out.
Before closing, I'd like to check with the staff team to see if they have any clarifying questions for us. I want to thank everyone for participating today, our expert panelists, my PTAC colleagues, and those listening in. We will be back tomorrow at 9 a.m. Eastern Time. We will be joined by Mr. Abe Sutton, the Director of Center for Medicare and Medicaid Innovation and Deputy Administrator for the Center for Medicare and Medicaid Services, who will be providing opening remarks. Our Day 2 agenda features a panel discussion and final listening session. The panel discussion will focus on enhancing the ability of population-based total cost of care models to be competitive. Then listening session 3 will focus on how to maximize participation of beneficiaries in accountable care and improve the sustainability of effective population-based total cost of care models. There will also be an opportunity for public comments tomorrow afternoon before the meeting concludes with the committee discussion. We hope you'll join us then. Thank you. This meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.